The organizers of this conference gave me the title Maternity Mayhem, and at first I thought that was a bit dramatic, except when I started thinking about the disparities in statistics. Looking at our maternal mortality rates, in the developed world, we look at 12 deaths of women per 100,000 live births. In the developing world, we're sitting at 239. In South Sudan, 1,360 women die for every 100,000 live births. That's probably exactly half this room. That is the true mayhem. Now, looking a little bit deeper at one of the causes of those maternal mortalities is pre-eclampsia. Pre-eclampsia every year kills 500,000 babies and 76,000 women. How late do they present? In low middle income countries, 2 to 17% of patients present with eclampsia. Significant difference. So, in my emergency center, I frequently see pre-eclampsia and its complications. This is despite the fact that we have a labor ward just upstairs. We can often see 2 patients with severe pre-eclampsia or eclampsia in a week. In Africa, patients present very late with pregnancy complications. This is for many different reasons: poverty, lack of infrastructure, resources, education, cultural beliefs, poor or no antenatal care, transport, geography, the list goes on and on. They also present to facilities often that are not set up, designed for maternal care, or who have the resources that they need available, even if they are. In the settings where you work, however, you probably don't see this very often. So why is this important to you? Well, if you don't see this often, there's a good chance that you could miss it a lot easier. So let me invite you to my emergency center for a shift. We see 2 obstetric emergencies in a week. We first meet Tandi. Tandi is brought in after collapsing at the shops. Initial assessment, we notice that she's obviously pregnant and she's profoundly hypertensive. And on our further assessments, we discover that she's got 3+ protein in her urine. Well, we know what the diagnosis is here. It's pre-eclampsia. So how do we define that? Well, one reading of a blood pressure more than 160/110, or not so useful in the emergency center, and that's 2 readings 4 hours apart, more than 140/90. In addition, the patient should have one of the following: either have protein in the urine of 2+ and more, or lab value urine, which we know we're not going to have back anytime soon, or one of the clinical features of severity instead, such as pulmonary edema, cerebral edema, visual disturbances, clonus, hyperreflexia, or lab values. Again, we might not get back quickly, but if we do get them, an elevated creatinine and lab values in keeping with HELP syndrome. So moving on, we know she's got pre-eclampsia. All right, let's get to the gist of it. So we're going to give her MagSelf as seizure prophylaxis, as shown by the MAGPIE trial. Now, dosage-wise, well, we'll start with 4 to 6 grams IV loading, and then we need to maintain her as further seizure prophylaxis. In a setting where you have access to an rate-controlling device or an infusion pump of some sort, you can give an IV infusion of 1 to 2 grams per hour IV. But the majority of the world that's treating severe eclamptics has no rate-controlling device or no way or resources to be able to monitor an infusion. So what's done instead is an additional loading dose given intramuscular, and then a 4-hourly injection is administered while the patient is waiting transfer to higher care. This is as effective as the intravenous dosing and doesn't require the same resources. Well, if she develops a seizure, you're going to load her with another 2 to 4 grams, even if she's on the infusion. So let's get back to Tandi. We're concerned Could she develop toxicity? We're giving her high doses of magnesium, so we watch out for decreased reflexes, respiratory depression, and muscle weakness. However, we note that she's actually anuric. She's got very severe disease. Knowing that magnesium is renally excreted, this is something of concern. Is she going to get toxic? And can we actually administer the magnesium? The answer is yes. Give the magnesium, just monitor for toxicity a little bit better. If the patient does become toxic, then you're going to give them 10 mils of calcium gluconate. Now, we know that she's hypertensive. We need to do something about that. We lower the blood pressure. If it is more than 160 over 110, we need to actively lower the blood pressure. But we get back to her and we realize after the mag self, her blood pressure's dropped down to 150 over 100. Don't be tricked by the transient, very fleeting hypotensive effect of the magnesium, which will often deceive people to think, okay, we can hold off for now. So we start preparing our next line of drugs. Internationally, irrespective of where you work, our first line in pre-eclamptics, severe pre-eclamptics, is labetalol. We start with 20 milligram and we double the dosing. However, most places, even where I work in a middle-income country, the majority of patients present to midwife obstetric units or primary healthcare clinics, and they certainly don't have the access to IV drugs, such as labetalol. They don't have access to staff to monitor, or it is not in the scope of practice of the staff at that local clinic. So the alternate option that's given in low-resource settings is nifedipine, short-acting. How far? Well, we're going to lower the blood pressure below 140 over 90 in order to prevent intracranial hemorrhages, which is one of the leading causes of deaths in these patients. Fluid is a massive problem in these patients. They get pulmonary edema very quickly and easily. Be incredibly, incredibly careful with giving any fluid. If your patient already has pulmonary edema, try and stop the problem from getting worse by increasing your concentration of your magnesium infusion so that you can decrease the hourly load of fluid, as well as treating with CPAP or invasive ventilation if you have that available, switching your antihypertensive agent from labetalol to an IV nitrate, and what is level 1 evidence in this category of patients with pulmonary edema is diuresis with furosemide. So we get back to Tandy, we start to examine her abdomen. We realize she's got a rigid, hard abdomen. We get our point of care ultrasound out and we see that there is no fetal heart present, confirming that she's got a grade 3 abruptio, one of the other significant complications of severe preeclampsia. We're concerned. She's at hemorrhage risk, multiple different reasons. Number 1, we chat to her family. The last fetal movements were felt 3 days ago. This is common for patients present so late. As a result of the delayed intrauterine fetal death diagnosis, she's at risk for coagulopathy. She's got multi-organ failure, so she has platelet dysfunction. She has HELP syndrome, so she has decreased absolute platelet count, as well as dysfunction. We need to be prepared that she can develop a massive hemorrhage, and we need to consider things such as transfusion protocols and rapidly stopping bleeding where appropriate. So let's get back to the emergency center. We're called for our next patient. We meet our next patient who comes in, brought by family. She's had a seizure at home. It's the first time. Because you've just listened to the talk, you've done a pregnancy test, confirmed that the patient's negative, and you notice that she's hypertensive. Well, you see these patients all this time. You start your first-time seizure workup, and you're initiating your management strategy. And then the ward clerk comes up to me and says, "Is it okay if I pop up to the peds ward quickly in order to fetch some milk for the 5-week-old baby that's with the dad in the waiting room?" And you stop, you panic, and you realize, I almost missed an eclampsia. Postpartum eclampsia occurs in, well, 1/3 of all eclampsia cases happen in the postpartum period. And this is where these cases get missed because people just don't put 2 and 2 together. All women are not just pregnant until proven otherwise. They also need to be potentially 6 weeks postpartum. Especially if you've got a patient that presents as an unknown patient with no ID and no ability to get a history. And this is just a patient with first-time seizures. Think, could this patient be postpartum? If you need to, because you have no other answers, look for clues. Look if your patient is lactating. Look if she's got a recent episiotomy sutures. Look if there's a recent cesarean scar to help you in your management. Right, so let's get back to Tandy. Tandy has severe pre-eclampsia. It's complicated by a grade 3 abruptio, complicated by coagulopathy, complicated by renal failure. She is critically ill. But Tandy's story is actually not that uncommon. It's quite common in most of the world. In my hope for the future is that in countries like South Sudan, that pregnancy will not be a death sentence because the social determinants of healthcare will be improved. My plea to you, as audiences that predominantly work in places where this is uncommon, is don't let that one patient sneak by without a diagnosis. Thank you.